All right. So in Australia, our custom is to show awareness and respect for culture and heritage through an acknowledgement of country. I would like to extend that acknowledgement to those who have come before us on the lands on which we are all finding ourselves today. So I would like to acknowledge the traditional custodians of the lands on which we gather today, whose deepening connection to culture and customs have nurtured and continue to nurture this land since the beginning of time. The land holds stories of conflict and loss, which, as well as rich and long lineage of cherishing and care. It offers us a common ground for storytelling, understanding, empathy, and respect as we strive towards a shared history. We pay our respects to those who have come before us, current leaders, and emerging for their immense spiritual connection to place, in which in some cases was never ceded, to the land and water, its knowledges, dreaming, and culture embodied within and throughout the lands on which we stand today. So thank you again for joining us for our webinar series. Today is all about patients and families engaged in resilient healthcare systems. So patients and their families contribute to the resilience of healthcare systems. This is particularly evident in global health systems experiencing increased pressure. So today we've got Dr. Harumi Kitamura and Carolyn Canfield to join us to share their insights into how we can create environments that invite patient and family contributions to resilient systems. So Dr. Harumi is an assistant professor and vice director of the Department of Clinical Quality Management at Osaka University Hospital, Japan. As a nephrologist, she works with patients with chronic kidney diseases, particularly peritoneal dialysis, with shared decision-making at the center of her practice. Harumi is dedicated to patient education and has founded a patient group with peritoneal dialysis and holds workshops in the World Cafe style in order to empower peritoneal dialysis patients and to promote their peer-to-peer networking. Carolyn, sorry, my computer's a bit. Carolyn Harumi will present her research in which she has empowered patients and their families to develop knowledge, confidence, and trust in themselves, their peers, and health professions. And she'll point to examples of where this has facilitated successful adaptation to disruption and the challenges faced in doing so. And then Carolyn will build on Harumi's talk, referencing the existing literature on patient and family contributions to resilience. And she'll give us some examples about how relationships among patients, their communities, clinicians, and their institutions can enhance resilience capacity. Carolyn is an adjunct professor at the Department of Family Practice at the University of British Columbia. Carolyn works as a citizen patient across Canada and internationally to expand opportunities for patients, carers, and their communities to partner with healthcare professionals to transform health systems. She is intensely passionate about collaborative experience and carries the patient perspective into the classroom as a co-instructor in patient safety and leadership synergies for first-year medical and nursing students. There'll be time for discussion and questions after the presentations, but for now, I would like to hand over to Harumi for her presentation. Over to you, Harumi.
Thank you for the introduction. Before I begin, I would like to express my gratitude to the organizers for giving me the opportunity to speak here today with Carolyn. My name is Harumi Kitamura, and as a nephrologist, I have been focusing on patient engagement, particularly for the people who are undergoing peritoneal dialysis. Today, I will discuss peer-to-peer interaction, which can play a critical role in achieving person-centered care more efficiently and effectively. I will share my slides. Wait a minute.
Perfect.
Okay. Then this is an outline. I'll start with the trends and barriers to person-centered care. I'll move on our research and practical 3 examples. I'll finish with a summary and mention future directions. Then let's look at person-centered care. Health has been defined as the complete absence of disease, mental, and social problems. Nowadays, since the state of complete absence of problems is not attainable, it is proposed that health is something more dynamic and positive. It is the ability to cope with chronic symptoms, mental and social problems, and to live happily. This is analogous to the paradigm shift in patient safety, which is not about a state of zero incidents, but about more dynamic and proactive management. Some of you may be familiar with Sarah Rigare. Diagnosed with Parkinson's disease at a young age, she is passionate about empowering people to take charge of their own lives. She said that doctors only see her for an hour each year, but she is an expert on herself, able to care for her body for 8,765 hours and recognize the effects of her own care. This is crucial. We need to approach these blue circles, which represent the patient's daily lives, in order to achieve the person-centered care. But how? This is work as imagined. To approach the patient mindset, the What Matters to You campaign and the SHARE approach have been advocated. In Japan, additional reimbursement for shared decision-making has been established in the field of kidney failure. These policies aim to promote person-centered care and patient engagement. But as I have been involved in patient education for many years, I realize how difficult it is to put these policies into practice. In reality, physicians and patients have different ideas about treatment goals. Recognizing and understanding this gap is very time-consuming and requires a lot of experience, which not everyone can do in daily clinical settings where time is limited. Patients are also struggling with the gap between the life they expected and the life they actually live with the treatment. Since there is no robust evidence or information, they are doing this by trial and error, groping their way through the process. This is the work as done. So let's move on the survey and examples on peer-to-peer interaction, P2P, which may resolve this problem. In order to find out whether patients actually need peer-to-peer interaction and what effect P2P has on their lives, we conducted a questionnaire survey on 111 patients with diabetes, kidney failure, and cancer at Osaka University Hospital. We conducted a text analysis of the written responses. The results are shown here. 1A, about 90% of the patients had difficulties in balancing daily life and treatment. 2, they wanted more information, time, and emotional and physical support. 3, 60% of the patients wanted to talk to other patients with the same disease. And this is the result of asking what kind of conversations they would like to have with their peers. The hierarchical cluster analysis revealed that patients' hopes, including sharing tips for life participation, treatment experience, practical advice, and encouragement, while their anxiety was prevalent feeling. In other words, They require experience-based information and mental support. Notably, the frequency of words shows that their anxiety is substantial. 49 patients participated in peer-to-peer interaction. The cluster analysis showed that they were able to share their experiences with one another and felt relieved. It is remarkable that many words were used to describe their vigor of life and positive engagement in treatment. These results suggest that peer-to-peer interaction can fulfill the patient's needs. The lived experience-based information and support from peers empower patients to not only survive, but also thrive. Let's look at examples of medical professionals bringing people together. First, the PD Cafe, which I introduced at middle part, is a program we offer to support patients with peritoneal dialysis and their family members. Since 2008, we have been holding an annual meeting for patients. In 2017, we changed the format from a lecture style to World Cafe style, providing a P2P platform. The PD Cafe's purpose is to offer a nurturing space where patients can share their experiences, knowledge, and worries with each other. About 40 patients and family members with various PD experiences, including pre-dialysis patients, participate every year. They write down the comments and advice they receive from other patients on paper. Effects of PD Cafe were as follows. Number one, it was an opportunity to learn from the collective experiential knowledge to close the gap between the expected life on dialysis and actual life. Number two, at the cafe, patients became reassured through the empathy, and 90% of them felt a strong sense of connection among the group. Number three, the cafe brought patients the ability to anticipate. 80% were motivated to live more positively thanks to the cafe. Number four, P2P gave experienced patients a sense of self-esteem, knowing that they were able to help patients going through a similar process. I think that peer-to-peer interaction can be a key to empowering both experienced and newly diagnosed patients. Number five, the last one, through the cafe, healthcare providers noticed the power of patients and realized the importance of individualized approach from the patient's point of view. Now let's look at another peer-to-peer support system, which I call Meet the Experts. At the outpatient consultation, which I introduced at the RHC network in Japan. Although the PD Cafe is held only once a year, patients always want to know other patients' information. So at our daily outpatient consultation, I have been providing a Meet the Experts experience for the past 20 years. This diagram shows my outpatient PD clinic. Here, a pre-dialysis patient and his wife came to decide on dialysis modality. He had chosen PD, but his wife didn't think PD was the best option for him. In the next room, a woman came in who had been diagnosed during the previous clinic visit that she would need to undergo dialysis in 2 months. She looked pale and had no expression on her face. She was thinking that she would be almost dead after starting dialysis. Outside the room, an experienced PD patient and his wife were waiting to see the doctor. Only one doctor and one nurse had to handle this complicated situation within a limited time. What could be done? It's easy. The power of peer-to-peer communication can solve this problem. Remember, every PD patient is an expert patient. So I asked the PD patient and his wife to share their experiences with the pre-dialysis patients and invited them into the room. Then we opened the partition. Okay, let's meet the experts. They met each other and began to ask and answer questions freely. The experienced patient explained from his experience and with true empathy. And the woman who had no expression on her face felt relieved to know that the experienced patient was keeping his lifestyle the same way as before. Her face cleared. The greatest advantage of this meet the expert is its ease of use. All we need to do is bring patients together. Medical professionals generally only listen to them. This system is extremely efficient. It would be nice if every hospital could connect patients with each other, but in reality, not all hospitals can offer such an opportunity. So now we are working on creating a P2P simulating video. This is a scene from the filming. The actor playing a depressed patient who is told that he will soon need dialysis is asking questions to the real PD patient. There are no predetermined lines or scripts. The patient is telling us his true feelings in his own words. Once this video is ready, physicians at any hospital can provide a simulated P2P experience to their patients. This is a scene from the photo shoot. We also introduced the bag exchange in the car and the bathing scene at the hot spring in the video. We have presented the results of our survey and P2P examples. P2P enabled patients to share their personal experiential knowledge, and patients were able to efficiently gain the perspective and motivation to move forward with confidence. The medical professionals were also able to recognize and understand the gaps between the patients and them. The lessons learned here can be applied to future clinical practice to promote more person-centered care. In short, P2P has the potential to empower and motivate patients and providers. No matter how many guidelines and reimbursements are developed, it's difficult to accomplish person-centered care in the conventional framework of doctor and one patient, which requires much time and effort. Adding a P2P framework to the system will immediately make it easier to realize person-centered care in an efficient and effective manner. P2P is definitely a necessary mechanism, but the following are future issues to be addressed. How can P2P be implemented in a wider range of diseases and facilities? What are the points that are missing from the studies, and what should be clarified in the future? It would be great to get feedback from Caroline, the SHARE team, and others in the audience. Thank you for your attention.
Thank you, Hirumi. That was wonderful. It's wonderful to hear about the projects that how you're adapting this idea of peer-to-peer interactions and support and able to converting it so that you're able to reach a wider audience. I'd just like to invite any questions from the audience that people might have about your study. No? All right, got some thanks from Siri for a great presentation. All right.
Siri is applauding you for a great presentation. Yeah. Nice study.
Thank you very
From
much.
Veslemøy.
All right, well, we might invite Carolyn. Thank you, Hirumi. That was amazing. I think in the discussion afterwards, we'll probably have some collaboration on some answers to your questions in that spot. So I'd now like to invite Carolyn to share her presentation.
Okay, I'm going to try to do the slide share correctly here. Share screen. How is that? Looks good?
Yep, perfect.
So I'd like to compliment Hirumi by looking at the other end of the telescope in some ways. But first of all, greetings from Canada. Actually, to be honest, it's more wet than snow. But some of you will remember perhaps where the little red star is, that back in 2017, the Resilient Healthcare Net had a meeting here. And I'd like to take a quick trip down memory lane. Here's your postcard. It was the middle of summertime at UBC, looking over the Rose Garden. And I hope it brings back happy memories of dining under the fairy lights at the UBC farm and our esteemed colleagues, Dr. Kazue Nakajima and Dr. Ellen Delkas, enjoying a nice BC Okanagan Valley wine over dinner. And I was really delighted that they were able to join us in Vancouver. And I had a chance to return the hospitality that both had extended to me, Ellen in Norway, and the previous year, Kazue in Japan. So here I am with Hirumi in 2016 in November, and she's showing me her work. And, you know, she is so remarkable, noticing patients' unmet needs, seeing the value of patients exchanging experiential knowledge and skills with each other. I want to really recognize Hirumi's humility, her generosity, and her respect for her patients in taking this initiative with an eye to its contribution to resilience. And I'm going to try to connect some of these ideas to what systems resilience contribution they make. I think connecting patients like this helps the healthcare system to be safer, to have patients who are more prepared and aware, and also empower their interactions in clinical settings. So going back to this wonderful slide, it was during that meeting in Vancouver that I used Sarah Rigger as an example of a patient with tremendous expertise to offer us. And I've since read just a few days ago, the dissertation of a friend of mine who invented, based on Eric Hollnagel's work, in addition to work as imagined and work as done, how about work as experienced? And so I think that that's what Sarah typifies in her wonderful drawing here. She's a friend of mine, obviously remarkable. She trained as a chemical engineer and she's inclined to innovate. So she defended her dissertation about a year ago, and the title is Personal Science in Parkinson's Disease. So she is constantly working on resilient potentials in her own environment by observing, adjusting, revising, adapting, innovating. And that's what's going on in each of those blue dots. This enhances systems resilience. Now, some of you will be maybe tired of seeing these drawings again, But just as with every person with a chronic condition, Sarah encounters the complex adaptive system of patienthood. She manages these dynamic elements in her medical life, social elements, practical elements, and her own functioning. And this means building up resources, changing relationships, and perhaps taking on new responsibilities. So this is a very dynamic, complex adaptive system of patienthood. She uses it to redefine her life and how the system encounters her. And it's true for other patients with episodic illness that patienthood requires awareness and skills to navigate and succeed. And all of you know that from your own experience as a patient. So we're more conventionally looking at the complex adaptive system of healthcare. And here the complexity surrounds Sarah as she's in the middle. And she has to be sure that she can navigate this complexity and that the system navigates its complexity so that she gets what she needs from the neurology specialist services on that one day a year. So when these two complex adaptive systems intersect, a lot of things have to go right, or at least right enough for the system to use Sarah's time well to make good use of her data and experience from her previous 8,765 days. So those two galaxies that are traveling in different directions with different forces and different components, but they have a shared goal in the moment of intersection. And that's the need to occupy the same space with full attention and trust. And that takes a lot of adjusting and adapting across the systems. So you've seen this slide from me before and some of these ideas, but just very quickly, healthcare is a complex adaptive system. No one perspective is sufficient to describe it. And the best learning comes from occasions when many perspectives are fully participating. So the takeaways that I've been developing over a long while now is that healthcare is a collaboration, not a service that you just deliver. Healthcare is defined by relationships of trust, and therefore improving care is improving relationships. And that includes relationships among all the members of a healthcare team, not just the patient and family members of that team. Well, I think these bright ideas are showing signs of bursting forth into the mainstream. Many of you work in healthcare systems where the latest vogue for learning health systems is kind of taking over our jargon. But I would put forth to you that learning health systems really do rely on the involvement of patients and family caregivers. And this is from the US Agency for Healthcare Research and Quality. It's a diagram that is very often used. So in Canada, in 2018, a year before COVID arrived, happily, this study was undertaken, a rapid synthesis of evidence and collecting information from every province across the country to create a kind of structure for rapid learning health systems in Canada. And I was lucky to be a key informant. And in fact, I absolutely did affect the orientation of this study, how to create a learning health system. So in the appendix, there is emphasis on table 1. It's the first driver. Is systems are anchored on patient needs, perspectives, and aspirations at all levels. So the question is, how do you do that? Well, how do you bring the patient perspective into all levels of a learning health system? About a year later, this report came out from Canadians at University of Montreal. It's a conceptual framework for implementing learning health systems in Canada. And among its drivers, its core values, are 3 that are important for patients. That is, learning health systems will engage patients, families, and communities, and the general public as partners in governance and in activities, and so on. A well-designed system of governance will also share accountability. And a learning health system unites the stakeholders with a common interest, empowers those with marginalized voices, builds trust between members, and promotes a collective responsibility for delivering value to the members of the healthcare system, but also the public. So of course, our friends at Share are ahead of us. And as usual, in Stavanger, about the same time that last report came out from Canada, the Network for Care Research began. And I know we have some people in our audience today who can tell us more about the research work being undertaken involving family. Now, family means neighbors, friends, trusted helpers. And we know that this is all about the roles to be adaptive, to be resourceful, observant, to take precautionary actions. These are dynamic and resilient contributors to the healthcare system's resilience. So Share enables the learning health system by engaging the experience of these family caregivers as knowledge. Well, how do we do this better? Well, I'm really excited that the national launch of a project I've been involved with for a number of years happened yesterday. Today is its international unveiling. And this is work for a national framework on evaluating the involvement of patient and public members in research. And it is based on the experience of patient partners and healthcare professionals, especially researchers across the country. There is a website with the link here for you to explore after today's talk. This is the main infographic. It's not how to do these things, but what to do. And I'm going to go to the website, if I can manage the slide sharing, new share. Here we go. There is an interactive, I'm online now. There's an interactive PDF that you can download. So I'm going to just show you how this works. So here you see at the beginning of the journey, there are a number of different icons for principles to address that may or may not be applicable in your project. And this goes beyond research. This is patient partnership in all ways. So you may want to include diverse perspectives. If I click on that icon, I come up with elements that members of our data gathering and Delphi group picked out. And the things that are listed here are have a very high degree of convergence of consensus. So if I click on welcoming, because Harumi has really talked about the importance of having that welcoming environment for patients to participate. So here we see ensuring respect, trust, and transparency with the project team, empowering patient partners in their contribution to the project, ensuring the safety for all partners, and so on. The elements that have stars had over 90% consensus of about 150 experienced patient partners and researchers. So it was and there were 3 rounds of the Delphi. It was an intense project, and that came after collecting ideas. So all of the words on this infographic I can click. If we look at including as another important element, openness towards different ideas and diverse perspectives, bring diverse perspectives into the project team, recognition and awareness of health inequities and inherent biases. So there are a lot of values here that are important in particular projects to a greater or lesser extent. And again, this is not about how to do these things, but what you should consider. They're based on these guiding principles at the bottom. So it's relationship building, co-building within the project, equity, diversity, and inclusion, support and barrier removal for the patient partners, transparency, sustainability, and transformation. And here, coming out of the process of developing a collaboration in a project is working through the transformation of the system. And at the top, the systems are person-centered, they're learning health systems, and the healthcare system has accountability. So I'm going to go back to my other slides. I think I can do this. Now, many of you know that I've been involved in a lot of different things, and I keep adding new cartoons to this page. All of the work that I do is about enhancing the knowledge exchange between patients and healthcare professionals. And in the last few years, I've been going upstream to influence tomorrow's health professionals. I'm just finishing my 10th year of teaching patient safety at the University of British Columbia. And thanks to all of you for helping me have the confidence to be able to do this well. I'd like to share with you that I've just received a certificate of merit from the Canadian Association for Medical Education. I think I'm the first patient to receive it. It's been around for a while. There were 3 from the University of British Columbia this year, and every medical school across the country has 2 or 3 recipients. And I'm, the only person without an MD or a PhD in the whole community over all years who have received this award. So I owe my thanks to you because many of you have assisted me. So when I think about this, the importance of going upstream, how do you bring patients into that? There's a new driver of social accountability that's affecting a lot of medical schools and training health professionals in general. So it's now an accreditation requirement for Canadian medical schools to demonstrate social accountability. And I've worked on the team to help prepare this study. It was funded by the Royal College of Physicians and Surgeons of Canada and conducted at UBC. And the recommendations here are reflections of what patients and society need in order to bring social accountability to the medical school. And it is, as you might imagine, through co-teaching. So here's the kind of people at UBC who work with medical students, but all the health professionals as well. Here's an example of one of those complex adaptive system diagrams from a person who is recovering from a stroke. And over 6 months, that person will be partnering with interprofessional students to explain how that dynamic works. And you see there's the sign ideal over that, that this is when things work well, those threads are connected. But this is sharing knowledge about complexity, sharing knowledge about the contribution patients make through their skills and their awareness and their expertise in their condition. These interprofessional exchanges affect these students for the rest of their careers. They're all preparing to thrive in a dynamic and hazardous environment that is healthcare with their patients. So I think that these partnerships do demonstrate the way in which patients and family members can contribute to a more resilient healthcare system by really enhancing connections, enhancing communication and awareness and trust. So thank you very much. I'm finishing off with a picture of witch hazel, which is in bloom now at UBC. In Japanese, it's called mansaku, which Harumi tells me means that it's said to bring spring. So I wish good wishes to everyone in the Northern Hemisphere for early spring and a beautiful spring. And I offer hopes for a beautiful fall for all of those of you who are in the Antipodes in New Zealand and Australia. Thank you so much for your attention. We need to keep talking. I'm happy to communicate with anyone on this call or watching this recording anytime. And we have time for some questions, comments, and ideas. Thank you very much.
Thank you, Carolyn. That was amazing. As you were talking, I'm like, this is exactly how we should be doing research. But then part of my brain was quite frustrated about how some of the barriers that we experience in terms of actually connecting with patients and their caregivers get in the way of actually co-creating our systems. Does anyone have any questions or thoughts they'd like to share? I should be a bit slower given I was a bit fast last time.
I think we have a question from Birte. Would you like to say something?
Yeah, it was actually a question for Harumi. With what do you do with the patient confidentiality, bringing different patients together? Because that's in my work as a nurse, that's always what you're scared of in bringing patients together.
We don't. They participate the cafe or meeting voluntarily. Only person who want to share information. So some person who don't like to share their own information, they don't participate. So I think they agreed to share their information at that space, I think. Is that okay?
And then we have Caroline.
Yes, I can elaborate a little bit. Think, Beata, of what it's like in the waiting room.
Receptionen sitter här till klockan 12.
What it's like at the waiting room in the clinic. Patients may or may not talk to each other. Family members may or may not talk to each other. And Harumi has given examples of the informal connections happening first in the waiting room, and then being able to use that friendliness to encourage it, to support it for the exchange of information, and leading to the more formal ways of the World Cafe setting. What I would say to Harumi's question about how do we institutionalize this or regularize, normalize this connection with experienced patients and newly diagnosed patients, for example. I've been, from my position in the Department of Family Practice and a disturber, that's my job actually, is to be a friendly disturber, is to encourage family physicians particularly, because they're dealing with the longitudinal care of their patients, to connect up patients in their own panel who would be willing to talk to newly diagnosed patients. The kind of information, as Harumi has beautifully illustrated, is information that the clinic doesn't have, the physician doesn't have. This is lived experience that is out of the realm of the clinician's experience, and it also is local. And that's one of the real powers of making these connections within a group family practice, for example, where there are perhaps tens of thousands of patients, among whom there will be some who can be approached to make those connections. It can also be hosted in the same way as that we organize today with a nurse educator, a diabetes education class for patients who are newly diagnosed with type 2 diabetes. That can turn into a World Cafe type discussion so easily. Instead of being a talking head at the front of the room with slides, it can be gathering together experienced patients to attend those sessions as well, because they in fact may have more useful information than the nurse educator. So that could apply to cancer. That could apply to, any kind of diagnosis where there's a likelihood that the lived experience is unknown to the clinician and will help with anxiety and planning your life, knowing that you have a life through this, that there is a future.
That looks like we've got another question for you from the amazing Siri. Harumi, what inspired you to start the World Cafe approach? And did you have any concerns when you were setting it up?
Thank you for your question. At this Department of Clinical Quality Management, there there is an experience to hold World Cafe on the theme of non-technical skill. So I learned the effects of that World Cafe method. So I use the method to peer-to-peer interaction.
You know, I was just thinking about another dynamic here that is important to recognize, and perhaps you've done this in your private life outside of your role in healthcare, going to the internet and finding patient groups where most of the questions are actually about the lived experience with that condition. And those support groups can be tricky because, again, the confidentiality issues, reliability of information, and so on. I think that especially specialists can be very helpful in being able to advise their patients where there are opportunities to connect with other patients who are already down the path ahead, where this newly diagnosed patient can find information. So, you know, there's no question that in this day, we go to the internet to find answers to our questions. Providing guidance is an incredibly useful skill that you can exercise, again, with generosity and understanding and respect for the position your patient finds themselves in.
I'm just wondering, so it sounds like these are all really ideal and great options to connect patients with this additional support network, but I'm just wondering if there are any, like, are there any sort of screening processes, or because I'm just like, in the back of my head is this concern that you could, that the patient could enter a forum that's not necessarily helpful, that the people who are collaborating on sharing their advice could be quite forceful in their point of view and saying this is the only way, and they might get misinformation about.
Well, I think, Lil, this is the real world. This is the world we live in. You know, I mean, you can't stop somebody from going to Dr. Google or whatever pejorative way you want to call that source of information. So I think providing guidance, providing education to patients about how to tell if a website is evidence-based or not. There's a lot of work being done in this area. I work with a radiation oncologist who has a special interest in providing her patients with some guidance. And I think that I can probably share after the talk today a list of about 10 strategies that she's used with her patients to question the reliability and the accuracy of any given website. But you know, connecting with the lived experience in person is has lots of social values in addition to just the information exchange. Not feeling alone. Feeling as though you can do what's ahead.
I was sort of more in terms of the type of personalities you meet in the world. Not everyone's sort of generous or soft in their approach to sharing their experience. So I just wondered if that was like a more of a filtered sort of experience. But I suppose, as with any sort of social situation, you got to rely on people having their own sort of approach to it. Ruth?
I think we should invite Ellen first and then Ruth. You have a question in the chat, Ellen?
Yeah, in the pictures, people look comfortable and friendly, and I'm wondering what you do to set that mood to make it so people feel that way when they come to the meeting.
Thank you. First, I share my ideas with my nurses, colleagues, and I we tried to make a group so that their backgrounds look like. For example, a table of patient's wife's table, and they are talking with each other about their husbands, and, or a table of young man who works very hard at the office, how to continue their work and the trip to work. So we tried to we tried to promote the conversation. We make a group of similar background people.
Yes, then it's Ruth.
Ruth, before you start, if I can add something to Harumi's, one of the strategies for getting people comfortable and interacting with each other, we take from First Nations traditions, and that is start with food. Start with a shared meal. And Harumi, I know you do that as well. You start out with the social connection of breaking bread, of sharing a cup of tea. And there is something about connecting over that pleasure and neutral and familiar setting that puts people at ease. And then it's an easier transition into talking about more difficult subjects. So I recommend starting with food and a generous time, you know, to not try to rush this, but allow people to have spaces of silence for chit chat, for quiet conversation.
I was just going to make an observation based on what you were saying, Lil. One of our PhD students, Darcy Tilbrook, is looking at basically patients' experiences of being involved in their care of being involved in their breast cancer care during the pandemic, and she's putting a resilient healthcare lens on the work that she's doing. And some of her patients who had been diagnosed pre-pandemic had found that a lot of the support groups, particularly the ones that are in person, had been really, really helpful in these exact peer-to-peer support that they'd managed to get around advice and experience and tips and things about how to manage their care and their treatment and things. And then when the pandemic happened, obviously all of those face-to-face and actual formal networks ceased, and they stopped being able to go to them. And some of them turned to some of the online forums and actually found them a very scary and very unmoderated place. And so I wonder whether there's just a way of, if we are moving to making things more accessible and online and things like that, if there's a way that we can set up that system in a way that does protect people where they need protecting, with moderators and things like that, because there's obviously a lot of benefit, but I think people can also find it quite a horrible place as well at times. It's just an observation.
Yeah, I think this is part of offering caring and kind care. You know, Victor Montori has developed some really brilliant ideas through his Patient Revolution work, and there's a website, if you Google Patient Revolution, or maybe even The Patient Revolution, and Victor Montori's name, a transformation to inject more compassion and empathy, or perhaps return to more compassion and empathy for the experience of ill health, for the experience of treatment, for the experience of recovery. And this is not only a driver for better patient experiences, but it is enormously rewarding to clinicians. No one wants to work on an assembly line when it has to do with human health. So returning to opportunities and encouragement and peer encouragement for supporting patients in navigating websites to find reliable information, reduce the anxiety, improve the self-confidence, improve self-management of chronic conditions or of acute conditions. So I think there are a lot of resources around for how to offer that generosity and respect to your patients in ways that are genuinely helpful, and as you say, insulate patients from exploitation or just negative experiences, being misled or taken advantage of.
We have time for any last comments or thoughts you might like to share before we wrap up. All right, well, I'd just like to thank you again for giving up your very precious time and joining us for a discussion on the relationship between patient involvement and the system's adaptive capacity and resilient performance. Thank you again to our most wonderful guests, Harumi and Carolyn, for sharing your experiences and ideas, thoughts and resources and perspectives. Our next webinar will be held after the Resilient Healthcare Society meeting, which is the 23rd of May to the 26th of May in beautiful St. Augustine in Florida. So we're looking forward to seeing you all there, and I hope you stay safe and well in the interim. And it looks like Caroline has shared the link to the Patient Revolution as well. Thank you, Caroline.
Victor has a wonderful book, and the website is just in the process of being redeveloped. I've been working in this group. Victor Montori is a specialist in evidence-based medicine and has quite a reputation. You can Google him for great editorials. Thank you so much. It's lovely to see everyone. Take care.
Thank you. Lovely to see you.
Thank you very much.
Thank you, Caroline.
Caroline.
Bye.
Thank you. Caroline, thank you very much.
Harumi, it's wonderful to see you. Thank you for your presentation. It was beautiful.